We're very excited to have our first years present 3 of the key trials from HA from this past weekend. So just to kind of lay the outline for today. So for each group, I'll first briefly introduce the speakers, and then each group will spend about 10 minutes to summarize the trials, and then we'll have about 5 minutes for questions and discussions after. And then I'll keep an eye on the time to make sure we stay on schedule and allow enough time for all presentations. So let's get started. We'll start first with Hannah, Evie, and Simon presenting the option trial. So I'll introduce Hannah, Evie, who are here with us today to share the results. So Dr. Hannah Burstein grew up in Washington, D.C. and completed residency at UC Davis, where she also served as the chief resident before coming to UCSF for fellowship. She's interested in interventional cardiology. And Dr. Evie Venmo grew up in Greece and received her MD degree from University of Athens. She completed a research fellowship at Minneapolis Heart Institute Foundation and internal medicine residency at Yale before joining us for fellowship. She is also interested in interventional cardiology. So you guys go ahead and take over, and then let's hear about the option trial.
Hi, everyone. Thank you so much, Evelyn, for the introduction. On behalf of Hannah, Simon, myself, we're going to talk about the option trial. This is not an interventional trial, it's an EPIC trial. Next slide, please. So a little bit of background. Currently, patients who have AFib and undergo AFib ablation and they're at moderate to high risk of stroke remain on oral anticoagulation regardless of the outcome of the ablation. A little bit of background for this is that although some observational studies have identified lower stroke risk after catheter ablation, randomized clinical trials with catheter ablation have not demonstrated reduction in stroke. The guidelines say that given that there is absence of randomized data, given that there is absence of consistent data demonstrating a lower stroke risk after ablation and increased rates of stroke among people with SATS-VAS score more than 2 who discontinue oral anticoagulation after 3 months. Patients who have undergone catheter ablation AFib should continue anticoagulation beyond 3 months based on their stroke risk if it's moderate to high. Next slide. So these are the 2023 guidelines for AFib. In recommendation number 4, we can see that there is a class of recommendation number 1, with a level of evidence BNR, meaning that there's modest quality data coming from non-randomized studies for this recommendation. Next slide. In this context, the comparison of anticoagulation with left atrial appendage closure after atrial fibrillation ablation, the option trial was designed to determine whether left atrial appendage closure with a Watchman device can safely decrease the risk of bleeding associated with oral anticoagulation while maintaining a low risk of stroke among patients with atrial fibrillation who have undergone catheter ablation and are at moderate or high risk of stroke. So this is not everyone. This is defined as SATS-VAS score of at least 2 for men or at least 3 for women. Next slide. So the study was designed to enroll 1,600 patients with non-valvular AFib with the SATS-VAS score that I mentioned, and they were randomized to undergo AFib ablation, Watchman, and short-term oral anticoagulation and aspirin for 3 months, or AFib ablation and oral anticoagulation. And they were followed for 3 years. Next slide. The inclusion criteria were that patients have undergone prior catheter ablation procedure for AFib between 3 and 6 months before randomization or within 10 days after randomization. As I said, SATS-VAS score more than 2 for male patients and more than 3 for female patients, and they should be suitable for anticoagulation. The key exclusion criteria were that if they required AC for other reasons other than AFib-related stroke reduction, if they weren't suitable for anticoagulation or aspirin for any reason, if they had heart failure with an EF of less than 30%, if they had recent stroke, bleeding event, or MI, and if they had history of ASD or PF4 repair. Next slide. So the trial endpoints. So the primary safety endpoint was non-procedure related bleeding, which was defined as a combination of major bleeding and clinically relevant non-major bleeding through 36 months. And the primary efficacy endpoint was a composite of death for menopause, stroke, or systemic embolism at 3 years after randomization. Next slide. With an 85% power to detect non-inferiority with respect to the primary efficacy endpoint in the intention to treat population. The non-inferiority margin was calculated at 5 percentage points, and that assumed that the primary efficacy event would occur in 10% of patients in its group. Next slide.
Hey, this is Hannah here. So I'll be taking over to kind of take us through the results. So a total of 1,600 patients underwent randomization at 106 sites in 10 countries over approximately 18 months. 803 were assigned to the device group and 797 assigned to the anticoagulation group. 50 patients in the device group did not receive a device and continued treatment with oral anticoagulation. 9 of which was due to unsuccessful implant, and 1 patient was assigned to the anticoagulation group, did receive a device in a trial error. A total of 82 patients in the anticoagulation group crossed over to the device group, and then 62 of these patients, or 82%, did so after a primary endpoint event occurred. Baseline characteristics appeared to be well balanced between the 2 trial groups and are shown in this table. And the groups were overall pretty representative of patients with atrial fibrillation who undergo the catheter ablation procedure. Some important characteristics to point out: the mean age of patients was around 70 years, and 34% were women, following the known trend of AFib trials and cardiology trials in general to under-enroll women, despite having a higher stroke risk. The mean CHADS VAS score was 3.5 with a standard deviation of 1.3, which I would classify as a moderate stroke risk. And then the mean HAS-BLED score was 1.2 with a standard deviation of 0.8. Additionally, approximately 40% of patients had paroxysmal AFib and 60% had persistent AFib. And we know that patients with persistent AFib have greater recurrence after catheter ablation. And then follow-up data at 36 months were available for 94% of patients in the device group and around 92% in the anticoagulation group. Overall, 95% of the patients received a non-warfarin anticoagulant. A majority, 60%, received apixaban, 27% received rivaroxaban. Throughout the trial, 84.8% of patients in the anticoagulation group continued to receive oral anticoagulation. In the device group, 10% of patients were receiving oral anticoagulation at 36 months, and you can kind of see the trend of how long they were continuing on anticoagulation. Reasons that patients continued oral anticoagulation in the device group included cardiac ablation or cardioversion, delayed follow-up visit or protocol deviation. And then 30 patients had a device-related findings, so a peri-device leak, a device-related thrombus, a migration or position issues. And then 28 did not receive a device. In the device group, implantation was considered by investigators to be successful in 98.8% in whom implantation was attempted. Complications related to the device or procedure occurred in 22 patients in the device group and in 1 patient in the anticoagulation group who crossed over to receive a device. A complete seal of the left atrial appendage with the device was observed in 81% of patients at 3 months and in 79.7% of patients at 12 months. And then the 12-month incidence of device-related thrombus was around 2%. And then at 36-month follow-up, 75% of patients in the device group and 77.7% of patients in the DOAC group were in sinus rhythm. So kind of looking at our main results here, non-procedure related major bleeding or clinically relevant non-major bleeding, which was the primary safety endpoint, occurred in 8.5% of patients in the device group and 18.1% in the anticoagulation group. This was a marked reduction and was largely attributed to a decrease in GI bleeding and epistaxis when you look at the supplemental material. This was significant for superiority. And then death from any cause, stroke, or systemic embolism at 36 months, which is our primary efficacy endpoint, occurred in 41 patients, or 5.3% in the device group, and in 44 patients, or 5.8% in the anticoagulation group. ISTH major bleeding, including procedural related bleeding through 36 months. So our secondary endpoint occurred in 30 patients, or 3.9% in the device group, and in 38 patients, or 5% in the anticoagulation group. And so this met criteria for non-inferiority, but not superiority. The p-value for superiority was 0.28. And so here, kind of looking at our endpoints, we can see our Kaplan-Meier curves. We do see a significant separation of the curves here. However, I would like to point out that this purposely excluded device or procedural related bleeding, and a majority of the bleeding events that occurred were epistaxis or GI bleeding. Moving on to our primary efficacy endpoint, we can see overall low event rates overall with no significant separation of the curves. And then finally, for our secondary endpoint, which does include procedural bleeding, again, we can see, modest separation of the curves, which is not significant for superiority. So now to kind of open up with the discussion and get us started a little bit. This trial demonstrated a significant reduction in non-procedure related bleeding for left atrial appendage closure compared to oral anticoagulation, which was mostly driven by GI bleeding and epistaxis. The observed percentage of patients with bleeding at 36 months in the anticoagulation group was 18%, which is high despite the relatively low HAS-BLED score, which I think emphasizes the challenges with long-term oral anticoagulation. Some limitations to this trial, in my opinion, include the intent to treat analysis in a non-inferiority trial. This is known to be problematic as it may inadvertently favor a conclusion of non-inferiority by diluting any potential differences between treatment arms. It's usually recommended to analyze both intent to treat and per protocol analyses to confirm non-inferiority findings. It's also an open label trial, which inherently can introduce bias. And then patients with heart failure, either, clinical or just a reduced EF were excluded. And so these results might not be applicable to those patients. And then some critiques kind of piggybacking off of some of the conversation at AHA was that superiority for safety was met using an endpoint that was arguably biased in favor of the device as it excluded procedural bleeding. And then we see in that secondary endpoint, had they used procedural bleeding, superiority would not be met and the Winn criterion would not have been satisfied. So I think it was an interesting point to bring up. And then another critique of the trial was that inclusion of death in the composite non-inferiority endpoint can bias the results. No study in either ablation or appendage occlusion has found statistically significant decreases in all-cause death, and rates of death were similar in the two groups. So because of this, no difference in outcomes is a positive result in a non-inferiority trial. Adding a relatively common endpoint, which is not affected by either treatment, makes non-inferiority easier to reach. And so overall, I'm curious to hear thoughts from the audience, especially those who perform Watchman procedures, if this will change their management. Thank you.
Thank you, Hannah and Evie. So now we'll open up to questions, and love to hear from EP faculty too. What Hannah mentioned.
So, real quick, nice job, everybody. From a clinical trial standpoint, it is a rigged trial, as you pointed out. There was no way that this trial could have failed because they excluded the procedural bleeding. And of course, there's going to be less bleeding in the group that's not on a DOAC. So it would have been much better if they had real hard outcomes for superiority and non-inferiority, and didn't include mortality. It would have been a real different study, and the results would have been different, as you mentioned. So nice analysis of the limitations, and I agree with all those things.
Thank you,
I have a
Jeff.
question for the EP folks. So this trial is clearly rigged, so to speak. So not surprisingly, you're going to have more procedural bleeding probably with a procedure and less post-procedural bleeding in patients who aren't on an anticoagulant. But as we accumulate data that, at least when it comes to ischemic outcomes like stroke, at least it adds to that data where we're seeing that the ischemic outcomes are similar. So if you can get somebody through the procedure, it seems more and more likely that at least it's equivalent, to anticoagulation, the appendage closure itself, long term from a stroke standpoint. Are we comfortable with that yet?
Yeah, I know Greg has his hand raised. Do you want to answer that?
I don't know that I completely understand the question. I think what you're saying, Sam, is that, and this has been suggested by the current evidence, which is the longer you go after a successful procedure, the benefit essentially accumulates, because presumably you kind of enjoy the stroke prevention, but don't have the ongoing bleeding risk. So that's one of the arguments in favor of placing these, but I think, there's still some question as to the overall risk benefits. As Jeff kind of pointed out, I don't know. And I wanted to make one other point, but Sam, does that address your question?
Yeah, in my mind, and I know that if you look at like the registry data of the actual use of this device, a lot of people aren't actually using the anticoagulation periprocedurally like they're supposed to, using antiplatelets instead, for example. I'm just wondering if it really is a viable strategy for those who can't take anticoagulation at this point. We think at least for secondary stroke prevention, for folks that really don't want to be on anticoagulation. It seems like it is.
Yeah. I think there's no question, for those who are poor candidates for anticoagulation, it's a good solution. And the open question is, well, is it actually a viable alternative to anticoagulation for everyone more broadly?
Yeah.
And not to be too cynical about it, but one way to look at this trial is that, number one, all the other prior randomized trials were compared to warfarin, which is a major ding for them, right? The Boston Scientific, and they want to do a study that shows, oh, look, now we're going to compare to DOAC. We're just as good as DOAC, if not better, in this trial. So it's kind of like they're looking for a way to make it appear, and maybe it is. I think, I can share my general views on this, but I think that this was very strategic, not surprisingly, from the company, and so we have to kind of take it with a grain of salt, recognizing, this was not an investigator-initiated PCORI or NIH-funded study, right? This was an industry-funded study. Not that there's anything inherently wrong with that. That's fine, but that's just part of the context we should think about. The other thing that I was going to mention is it's interesting, to think about, well, does the left atrial appendage actually contribute something useful? Does the contraction of the left atrial appendage help with exercise tolerance? And it's one thing to think about patients with a lot of comorbidities, they're contraindicated to anticoagulation, that's less of a concern. But when we start to think about extrapolating to all of our AFib ablation patients, many of whom are extraordinarily functional, very physically fit, and just thinking about a world where we might consider as a reflex, oh yeah, let's also close the appendage or occlude the appendage. I would love to see some, exercise capacity data and very careful quality of life data, because I don't think we know the answer to that. And because many of these patients are going to do really well over time, I think we need to be careful about extrapolating broadly. I see Dan Morin, our new EP faculty, is on the call, and look forward to his thoughts. And just to share my summary view of this, and in my opinion, this wouldn't change my practice per se, but it might make me a little bit more comfortable reaching for the Watchman device for patients who are especially motivated or in whom I'm worried about bleeding. I do worry a little bit about those in the community that also have arguably a perverse incentive. And again, I apologize for sounding too cynical, but where there is an RVU benefit to doing these devices, this is potentially unleashing them a bit. And again, we just need to be thoughtful about these things.
I guess that is an introduction of me. So thanks very much, Greg, for the welcome. And it's a pleasure to meet virtually with our junior fellows. So I just started on Monday. I'm an electrophysiologist. Been doing this for about 16 years. And I do place the Watchman device. I have not placed it simultaneously with an AFib ablation procedure. One thing that Sam mentioned a little while ago is that people sort of said that people have not been anticoagulating these patients sort of the way that they should be for these devices. I just do want to point out so that everybody understands that it is FDA approved in select patients, particularly those with high bleeding risk, to just use dual antiplatelet both before and after placement of the Watchman device. The things that I'm concerned about, in addition to what Greg talked about in terms of contractility, is also the possibility that the exocrine or paracrine functions of the left atrial appendage might also be interrupted by placement of a Watchman device. So I'm a bit concerned about that, and also maybe there might be something that has to do with healing, because when we ablate, especially around the left superior pulmonary vein, which is right next to the left atrial appendage, sometimes that causes a bit of swelling there, depending on what type of energy source we're using. And also, placement of the Watchman device right afterwards might make it more difficult to perform a redo procedure, which unfortunately does happen, later on down the line. It might make it more difficult for us to successfully isolate the veins in the future. So there's a lot of different moving parts here, but I also agree with Greg that I'm not surprised that Boston Scientific sponsored such a trial, and I don't blame them for doing that. They have to get the research out there somewhere, and it's faster for them to host a trial than it is for them to wait for NIH to do it. And as long as the science is reasonable, as long as we have discussions like this, I think it's totally valid for them to perform trials like that.
All right, thank you. That was great discussions. There's some great comments in the chat too. I'm not gonna read all of them given our time constraint. So we'll move on next to Miranda and Bohao, who will be presenting the Summit trial. So I'll introduce them while they start sharing the screen. So Dr. Miranda Coley is from Cincinnati, Ohio. She received her. Are you guys having an issue with screen sharing?
We'll get there. Give us a second. I think we're okay.
Okay, great. So I'll continue with the introduction while you guys are working on that. So Miranda, she received her MD PhD degrees from University of Pittsburgh before coming to UCSF for internal medicine residency and cardiology fellowship. She's interested in pulmonary hypertension. And Dr. Bohao Liu grew up in Macomb, Illinois. He received his MD PhD degrees from Columbia University before coming to UCSF for internal medicine residency, and he's interested in general cardiology. All right, go ahead and take away.
All right, everybody can see our slides. Thanks for the introduction. So we will be presenting Summit, which is focused on the role of tirzepatide in treating HFpEF and obesity. So tirzepatide, taking a step back, there is an association between obesity and HFpEF incidence, particularly in women. And there are several hypotheses around how that works. The central hypothesis that the team around this study shared with us in their in-depth session really focused on the role of adipocytes, inflammation within the body, and even pericardial adipogenesis being a big portion of why, or HFpEF pathogenesis. In particular here, tirzepatide, for everyone to know, is a GLP-1 agonist and simultaneously also a glucose-dependent insulinotropic peptide agonist. So it has dual function, which makes it slightly different than Ozempic semaglutide. This study comes on the tail end of STEP-HFpEF, which did show symptomatic benefit in patients with HFpEF, but did not quite have the power to show decreased incidence of heart failure exacerbation or a mortality benefit. So here, speaking to the study design, we have an international multi-center randomized double-blind trial where patients were screened and then randomized 1-to-1 to receive either tirzepatide or placebo sub-Q injection on a weekly basis. The way they did this is they actually tried to get all patients to the maximum dose of 15 milligrams sub-Q over a 20-week period, given that the titration usually happens every 4 weeks. About 75 to 80% of patients were able to tolerate the maximum dose at 15 milligrams within this treatment group. Other important inclusion criteria were patients who had a BMI of over 30, who were NYHA class 2 to 4, with a heart failure exacerbation within the 12 months of screening for the trial, as well as patients who had evidence of preserved ejection fraction above 50%, with either elevated BNP, left atrial structural heart disease, or elevated filling pressures, and who were not going to have any sort of modifications to their heart failure, other heart failure medications, except diuresis over the course of the trial, and then who had a score of less than 80 on the Kansas City Cardiomyopathy Questionnaire, which will come up in our primary endpoints. Important exclusion were patients who'd already had GLP-1 therapies, already been treated with bariatric surgery, who had had reduced ejection fraction, obviously, and then a couple of comorbidities, including like ischemic heart disease, end-stage renal disease, PH, and then atrial fibrillation and flutter that did not have controlled rates. All right.
Miranda, do you know?
Go ahead.
Miranda, do you know what they defined as PH? As you know, many patients with HFpEF have PH, so I'm curious what they defined when excluding it. What they use as the definition. Was it PH or?
Yeah, so it's interesting. It was, I remember, so they kind of clumped it with pulmonary disease in the appendix. So off the top of my head, I know they excluded pulmonary arterial hypertension, though I don't know if they defined that with TTE or right heart catheterization. And then pulmonary disease was things like COPD, emphysema, things like that. In terms of a cutoff for, you know, PASP on a TTE, I don't remember that off the top of my head. It's a great question, though.
No worries, I'll look into it. Thank you.
Yeah. And then ultimately with that screening criteria, inclusion and exclusion criteria, our demographics ended up being as follows. It's a very long list, but ultimately wanted to draw attention to the fact that we did have an equal number of women between the groups and a predominance of women in this trial. And then also wanted to draw attention in the bottom left corner to the medications that these patients were already on. Divided between the two groups. Notably, given, you know, the data now seems to support SGLT2 inhibitor use and MRA in these patients as really a part of the pillars of HFpEF. This was a relatively treated group. Not a lot of these patients were on SGLT2 inhibitors to begin with. So in terms of their primary and secondary endpoints, ultimately, they ended up looking at a combined cardiovascular death or worsening heart failure exacerbation, a primary endpoint that included hospitalization, IV diuresis, and oral diuretic therapy increases. This, just of note, was a change from the initial intention of the study. They initially had plans for a hierarchical composite endpoint that included the aforementioned primary endpoints that they ended up pursuing alongside changes in 6-minute walk distance and improvement in patients' Kansas City cardiomyopathy scores. After STEP HFpEF came out in the middle of this trial, there was an effort to really try to isolate the cardiovascular death and worsening heart failure endpoint, given that STEP 2 HFpEF suggested that these things might be modulated but didn't have the power. And so this was changed halfway through. There's also a portion of the study that says that the FDA did a thorough review of this change in primary endpoint and ultimately felt that it would be easier to analyze, given that it's hard to include subjective outcomes in the Kansas City Cardiomyopathy Questionnaire and these endpoints, these primary endpoints they ended up with. All right, so based off of all of that, what they were able to find is that over the study period, which was up to 120 weeks, there was, or 120 weeks, that there was a decrease in the cumulative incidence of death and worsening heart failure events that particularly started to take hold beginning kind of in the 24 to 32 week area, notably after these patients were completely titrated up to the max dose of tirzepatide that they tolerated. The inlay is just a zoom of that. At the same time, looking at their other primary endpoint, there was improvement in Kansas City cardiomyopathy scores, speaking to the symptomatic improvement, subjective symptomatic improvement from patients. And then ultimately really trying to break down hazard ratio within certain subgroups. We decided to focus more on things like age, BMI, proBNP, and blood pressure here because we thought these findings were particularly interesting, that there seemed to be a favoring of tirzepatide in those who were older, in those with a lower body mass index to begin with, in those with a NT-proBNP less than 200, which suggests that there are some patients who maybe were being classified as having a heart failure exacerbation by NT-proBNP and then being left out of treatment. And then ultimately systolic blood pressure, whether that's the function of these, I don't know what the spread of these patients' other blood pressure medications are, or if there is something to be said that those with more difficult to control blood pressures don't benefit as much. It's a little bit hard to tell, but those are things we wanted to highlight. And then obviously a little bit difficult to interpret the subjective changes, as there could be subjective improvement in symptoms because of less HFpEF exacerbations, but also subjective improvements in symptoms just given weight loss.
All right, I'm Bohel. I'm going to talk a little bit about some of the secondary analyses and also the sub-analyses that came out of this trial that were also presented at AHA. I thought a couple of them were pretty interesting. This was published the day after in Nature Medicine, where the authors wanted to kind of break down a little bit more of what tirzepatide was doing and try to get a little bit more at the mechanism of action. There was a little bit more to this trial than just these figures, but I thought these were kind of the more interesting ones where they were able to show reduction in systolic blood pressure, that's as well as a reduction in estimated blood volume. So that was interesting with the tirzepatide group, one compared to placebo. And then the other thing that they showed, which I think was in line with STEP-HFpEF as well, is that the use of tirzepatide led to a decrease in CRP. That was pretty notable. That continued to be prevalent for the first year. And I think there was some comment about how the separation of the CRP trends really started happening in like around 24 weeks. Which is the same time that the heart failure exacerbate or their primary endpoints started to diverge. And I think there was also some thought that that was also around the same time when more of the weight loss was starting to pick up. And then the second kind of analysis that came out of all of this was an MRI study where the authors wanted to see whether or not there was any changes in LV mass or pericardial adipose tissue that were due to the use of tirzepatide. So again, there was a little bit more to the study than this, but I think the top of line kind of conclusions were that there was a significant reduction in LV mass as quantified by the MRI, as well as pericardial adipose tissue and the pericardiac adipose tissue as well. And then just like briefly comparing to STEP-HFpEF, which I think was published last year, looking at semaglutide, they, like Miranda was saying earlier, really were only powered to show this subjective difference, which they did. The magnitude was a little bit higher than in the tirzepatide trial that was published this year, but relatively similar. They did show that there was a trend towards having reduced hospitalizations in that trial. In STEP-HFpEF, they just weren't really to have the power to actually say that, which I think we were talking about had to do with why the primary endpoints ended up getting changed for Summit. And so the conclusions, I think, when you compare it to placebo, tirzepatide in HFpEF and obesity did show reductions in the worsening of heart failure events with improved health status through the KCCQ. And then I think one of the biggest things and the biggest questions that come out of this is whether or not this is driven solely by weight loss. So some of the limitations of this study, relatively short observational period. It was not the largest study, though it seemed to be pretty diverse. And the primary endpoint that changed in the middle of the trial, which is interesting that we can talk about. And then the other thing that actually came up in a lot of the discussions at AHA was their definition of a heart failure exacerbation. Is my understanding that this is maybe the first trial that included escalation of oral diuretic use as part of that definition, as opposed to kind of more traditionally heart failure exacerbation as defined by hospitalizations and IV diuretic use. Though they did show somewhere in the supplementary figures that their endpoint is not entirely driven by the oral diuretic escalation. So in terms of the outstanding questions that have come out of this trial, I think, like I was saying earlier, the mechanism is really interesting. There was a lot of questions about whether this was entirely related to weight loss or if there were other effects of tirzepatide as a GLP-1 agonist on different cell types, inflammation versus just like blood volume versus like if there was any specific effects on cells like cardiomyocytes, or is it just solely like an adipocyte issue? And so there was a question about whether or not we thought it would be interesting to know if patients that did not lose weight on tirzepatide, did they also show a reduction in mortality through the endpoints, or otherwise, if you could achieve weight loss through other methods, if you would have similar effects. There's also the question about HFrEF and GLP-1 agonists. There's some trials before we go into that didn't really show an effect, but given that here we have a slightly different mechanism, there's always the question about whether this should be studied in HFrEF. And then, like I said before, there was this interesting question about how we define heart failure exacerbations for future trials.
And with that, we can open up discussion.
Thank you, Bohel, Miranda. I think we have time for maybe one question or comment. If any from the audience, I know we have some heart failure faculty on as well.
Yeah, so hi, Ron. So I think the question about the endpoint, the heart failure endpoint, is a really good one. And you're right that this is the first study, to my knowledge, that has included escalation of oral diuretic therapy as part of that endpoint. I think that where we really need to be able to demonstrate improvement in heart clinical outcomes, including oral diuretic escalation as part of the primary endpoint, becomes a little bit tricky and can sort of dilute what we're looking for. I don't know, I wasn't at AHA, and I'm not sure what all of the conversation has been around that, but I personally think that sticking to some of the kind of better, clearly defined endpoints that are I shouldn't say easier, but more, there's more clarity around their definition, and the ability to adjudicate those events strengthens clinical trial outcomes. So I think it's a slippery slope there.
I thought one thing that was, it seems like they've done a lot of secondary analysis, and they're looking at more than just that composite endpoint. So I think one thing that's really promising is that reduction in NT-proBNP that they saw. And we know that, an NT-proBNP being persistently elevated is associated with worsening mortality. So in my mind, that was one thing that, I think strengthened the paper. And also the secondary analysis you showed about reduction in CRP and also reduction in adipose tissue.
At the discussion session for Summit, the room was pretty much split 50-50 on whether they thought increased oral diuretic use should be added into the endpoint.
Interesting.
All right, well, thank you, everyone. I think we want to make sure we have enough time for our last group so we can take the rest of the discussions offline. So next we'll have Ilyas and Shari tell us about Clear Synergy. I'll start with the introduction. Dr. Shari Kennedy grew up in Princeton, New Jersey. She received her MD PhD degrees from Harvard Medical School and completed residency at MGH. She's interested in women's cardiovascular disease and genomics. And Dr. Ilyas Nikolakopoulos grew up in Greece and received his MD degree from University of Athens. He completed a research fellowship at Minneapolis Heart Institute and internal medicine residency at Yale before joining UCSF. He's interested in multimodality imaging. All right, go ahead and take away.
Thank you, guys. Thank you, Evelyn. This is a trial named Clear Synergy Oasis 9, part of a registry for Synergy drug-eluting stent, PSRI trial, or otherwise routine spironolactone acute myocardial infarction. And basically, the concept behind it is that we do use spironolactone, but it has a recommendation for a limited amount of patients after STEMI, those who have heart failure, diabetes, and a reduced EF, and of course, contraindications like low GFR or hyperkalemia. So based on that, it is estimated that 1 out of 10 patients with STEMI is actually eligible for an MRA, and they wanted to investigate kind of like the effect at a larger non-selected STEMI population. It was designed as a factorial trial to also check the effect of colchicine after some conflicting results of smaller studies in the past. So they did design it as a 4,000 patient study. STEMI people were included. Some of them were part of the Synergy registry, some of them were not. And the main inclusion criteria was the STEMI. They later expanded it, and that's why the asterisk about the number and the STEMI. They later expanded it to include some non-STEMI cases because it was difficult to enroll. main exclusion criteria is that people were like not in cardiogenic shock, no low GFR below 30, and potassium was normal. So it was a fairly unselected, but mostly like healthy STEMI population. And they were quickly randomized to spironolactone or placebo and colchicine or placebo, which leaves us with 4 different groups. And the primary analysis for this one was spironolactone versus placebo. That includes colchicine or colchicine placebo as well. There was follow-up at 3, 6, and 12 months, and most of the people actually were followed up to 3 years. The second asterisk above the number means that the study was powered and for a 15%, I think, event rate, ended up having 9%. So they had to actually redo a power analysis in the middle of the study, and they ended up enrolling 7,000. Why does one do a factorial design? We saw that it allows us to evaluate for more than one intervention at the same study using the same sample size. And we can also evaluate for interactions. Usually we would do like a subgroup analysis, or we would do an interaction terminal regression analysis, but that requires a ton of alpha spending, and it doesn't preserve randomization, which is preserved here. And that's why this was designed as such. The primary endpoint was a composite, cardiovascular death or new or worsening heart failure. So now, to connect that to SUMMIT, actually heart failure was defined as escalation of diuretic that could have been oral diuretic escalation in clinic, or a heart failure hospitalization. It did require some other evidence like clinical exam that is consistent with pulmonary edema or imaging, like an X-ray. There is a second primary outcome, not directly powered though, that also includes other MACE components like MI stroke or MI stroke basically. Instead of doing time to first event, they tried to do an analysis that actually takes into account every event, which makes sense when we want to reduce heart failure hospitalizations, for example, because we need to make sure that within those 3 years, we decrease the total number of heart failure hospitalizations. The problem with that is that when you do that, when somebody suffers a heart failure hospitalization, there are increased risks to suffer another one, which can bias your estimate. And that's why they did this model, which is the Lin-Wei-Yang-Ging model, to adjust for the correlation in the standard error. They did an intention to treat, that was the primary analysis, and an on-treatment analysis that was not powered. The study was not powered for. Briefly, that's a great reference slide for all the different repeat events methods that we can use in trials. Some of them prioritize most important events like the win ratio. Ours just corrects basically for the multiple recurrent events and the difference in the standard error. And the most important thing to take away from that is that they're all actually much more conservative in their estimate than just the Cox model that looks at the time to first event. So we can take a look at the results.
So moving on to results. So the study, as Ilya said, enrolled about 7,000 people with a mean follow-up of 3 years, mean age around 60, and then about 20% women. And then, as he mentioned, the vast majority presented with a STEMI, about 40% anterior STEMI, most common was inferior. And then about 50%, half of the patients had a second lesion of greater than 50% stenosis, and nearly all, like greater than 99%, did not have prior heart failure, about 20% with diabetes. So looking at the first and second primary outcomes, spironolactone did not significantly reduce the new or worsening heart failure and cardiovascular death composite outcome, or the secondary kind of broader composite outcome. A couple things to note. First of all, the event rate was pretty low, about 2 events per 100 patient years. So this reduced the power, and also just kind of speaks to advances in our treatment of STEMIs, and kind of differentiates this trial from kind of previous results where they had more new heart failure, more death. Also, because of the factorial design, with colchicine, the rate of discontinuation was pretty high, almost 30%. And a lot of the patients who developed diarrhea, presumably from colchicine, also stopped spironolactone, so that affected their power as well. Looking at the individual outcomes, so in terms of mortality, there was really no sign of benefit, about 3% mortality in both the spironolactone and placebo groups. But when they look at new and worsening heart failure, there was actually a benefit for spironolactone. So about 30% lower risk of new or worsening heart failure in patients with taking spironolactone compared to placebo, which translates to about 2.4% with the placebo versus 1.6% with spironolactone. So still low. And then just briefly to comment on colchicine, which was also included in this. Here, the result was like really very negative. There was no benefit to colchicine in preventing death or major complications, and really and there were no benefit in any of the subgroups either. And then I thought it was interesting to note that when they looked at the CRP in the placebo and colchicine groups, and the CRP with colchicine was significantly lower, more than half the levels of the placebo. So it does seem like it was having an effect on inflammation, but that effect did not translate to a benefit for cardiovascular complications. So some limitations, as I mentioned, there was this high discontinuation rate. When they look at the on-treatment analysis for spironolactone, the hazard ratio was 0.8 and was kind of marginal significance. So maybe if they kind of repeated this trial and had better tolerance, they would see some benefit. In addition, they had this low event rate that reduced their power, and then also underrepresented women and non-Caucasians in the study. So major takeaways. So overall, spironolactone did not show a benefit, but it may reduce for death or stroke or recurrent MI, but may reduce the risk of developing heart failure. So kind of what we might take away from this is, patients with a higher baseline risk of developing heart failure after an MI, such as like a large infarct, a late presentation, or like an elevated LVEVP on their cath, those patients you might choose to start it with the goal of reducing their risk of developing heart failure. And then I think the question of like why colchicine in this study did not show any benefit, whereas in prior studies like the COLCAT study, it is really an open question. The patients were pretty similar. The one difference was that the prior studies included NSTEMIs and STEMIs, and the study was really majorly focused on just STEMI. So maybe there's some difference in the role of inflammation and the role of colchicine in those two populations. But I think it is still not clear, and kind of both the study, the trialists and the commentators kind of found it unclear why there was this difference. So further research will be helpful. So thank you. This is Simon, who is on nights currently, presenting his wonderful poster, and we'll take any questions.
All right, thank you, Shari and Elliot. So we'll open it up for discussion, questions.
I would just say it's like a very worthwhile thing to study on how you can, if we think about stage B heart failure versus stage C heart failure, and how you can prevent a patient from going into stage C. And there's a more increasing interest in that in our field.
All right. Well, thank you again, all the first years, for providing a great summary of the trials, and I'm glad to see you guys had lots of fun in Chicago and AHA. So thank you everyone for joining today, and we'll take a break next week for Thanksgiving, and then we'll come back again in December. Thank you.
Thank you.